welcome. How's it going? Good. Thank you for making it out in the rain. I know that that's always a tough part about going out during the week. So thank you for being here. We've also got a live stream going at the same time, so people on the internet can watch wherever. And that's the beauty about this. So everything that we put out tonight, all of this content, you can find later on our Facebook and YouTube. Which will be awesome. So if you missed a question or you missed a doc saying something that really resonated with you, feel free to look back, and hopefully this catapults us into more content throughout the year. So this is the first of 7 events, and I want to introduce it just because we've never done this before. We are partnering with an organization called Experience Anatomy. So this is Jamie Decker. She's the founder and CEO of Experience Anatomy, and they work with, they are an education and training company. They work with true specimens. For education and training, which is really cool. So they're going to use some of their plastinates and specimens to kind of show you a little bit of the behind the scenes, behind the shoulder injuries and treatments and new techniques and things like that. So if you have questions, you guys probably all see a paper on your chair with a pencil. Please write those down. We'll do questions at the end, but we'll do little 15-minute presentations for each topic. And that way, if you have thoughts, write them down. We'll collect them at the end. And then Dr. Hammond's going to speak to a panel. So we've got 3 great docs presenting for you. Dr. Natty Hammond's going to come up and give you guys kind of a rundown of the shoulder in general, just to kind of kick us off. And then we will get started with presentations from there. So thank you again for coming, and let's have a great event. Awesome. Cool. Mike's.
All right. Thanks, Elena and Jamie. So welcome, everybody. Welcome, everybody that's viewing online. We're really excited about this event tonight. We're going to discuss some really common shoulder conditions that we hope to arm you guys with some good information so that if you or your friends or family ever have to deal with one of these conditions, you at least have some information you can fall back on. So again, I'd like to thank Experience Anatomy, our partner in this series. We're going to be able to use some really world-class plastinates, and they have a world-class embalmment process here that we're really fortunate for a lot of healthcare professionals in Charlotte to be able to train here. And then they also have a lot of educational programs for middle schoolers and high schoolers that are interested in anatomy, so they can come here and really get a good flavor for it. Okay, so we are going to start with discussing really 3 common shoulder conditions today. And I want you guys to just kind of have an understanding of what we're talking about today, which is the shoulder joint. And the shoulder joint, just in its basic fundamentals, is a ball and socket joint. So it's a big round ball on a flat socket. And it kind of looks like a golf ball on a golf tee. And the ball should be able to move freely on the socket. In fact, this is supposed to be the most mobile joint in your body, is the glenohumeral joint, or the shoulder joint. And as the ball moves around, it has a little bumper of tissue around the socket that we call the labrum. And the labrum is what really keeps the ball centered on the socket. And then there's a capsule around the ball and socket joint. That just keeps the fluid in. And the labrum and the capsule keep the ball centered well, but allow you to have motion. And as young people start to have injuries to their shoulder, they can have problems where their shoulder likes to pop off the socket. So that's instability. That's where the labrum gets injured, the capsule gets injured, and the ball dislocates off. And what can happen after that is the ball can have a strong propensity to want to dislocate again. So we call that instability. Now, on the other side of that spectrum is stiffness, or we call frozen shoulder. And that's what Dr. Grant Mostak's going to talk about today, and that's where the capsule actually gets really thick and inflamed and limits the motion of the ball in the socket. So working from there, ball and socket, you have the cartilage surfaces on the ball and the socket. And the cartilage surfaces, imagine them like marble surfaces, really smooth, white surfaces that we have in all our joints. And that allows joints to move smoothly on each other. And what can happen is, over time, some people can lose the nice, smooth surface of the ball and socket, and that's called arthritis. That's where you lose the nice, smooth cartilage, and it becomes rough bone rubbing on rough bone. And Dr. Schifrin's going to talk about shoulder arthritis and the ways we can treat that. Okay, so around the ball and socket now, you have a group of muscles that I'm sure everyone has heard of. These muscles that surround the ball and socket, completely envelope it, is called the rotator cuff. Not cup, but cuff, C-U-F-F. And so the rotator cuff is a group of 4 muscles that envelope the shoulder joint. And these are muscles deep on the inside. You can't see them. They're deep under this deltoid muscle. And they're incredibly important with allowing us the ability to use our arm out in space. Anytime you move your arm out away from your body, you're activating those rotator cuff muscles. And almost everybody at some point in their life is going to have some problem with their rotator cuff. Hopefully it's not too bad, but some problem will develop at some point for people. Sometimes it's not too bad and you get over it in a few days, and other times it can be a life-changing event for you. So Dr. O'Neill is going to talk about problems of the rotator cuff today and talk about the different severity of problems you can encounter with the rotator cuff. But the reason I went into shoulder is I love the anatomy of the shoulder. It's so complicated. There's so many small inner working pieces that all have to work, and it's like a well-orchestrated symphony when they're all working well together. And so it's an incredibly fascinating joint, and we hope to kind of give you guys a little bit of a picture of some of the common conditions that can go wrong when some of those things aren't doing their job. Okay, so we'll start off with a discussion about rotator cuff disease, and that'll be by Dr. Scott O'Neill. Dr. O'Neill did his orthopedic residency down in Miami, and then he did a sports medicine fellowship here in Charlotte at Ortho Carolina at the Sports Medicine Center, and he's got a great practice in the Ballantyne area. So Scott, do you want to come talk about rotator cuff problems?
Thanks, Natty. Oh, water here. Excuse me, I'm losing my voice a little bit, so if I have to pause, I apologize. I'd just like to echo what Natty said. One of the reasons why I enjoy working on the shoulder so much is it is a really complicated joint. It's fascinating, and the things that we get to do on a daily basis when we treat these different problems can really lead to improvement in patients' lives, and it's one of the things I really do enjoy. So I was tasked with talking about subacromial impingement and rotator cuff tears. So just a little overview of what I'm going to talk about is just a real quick talk about the anatomy, what can be some of the causes of impingement, and then what is the treatment, whether it's going to be non-surgical or surgical. A little bit about the anatomy. For impingement, what we're kind of focusing on is the bony anatomy and how it interacts with some of the soft tissue. So if you look here on the screen, the picture on the right, that's an x-ray of the shoulder, and the overhang is something called the acromion, and what I labeled the greater tuberosity is where the rotator cuff comes and attaches. And what doesn't project well on x-rays is what's going on with the soft tissue, and that's basically where the rotator cuff has to live in that space, or what we call the subacromial space. So when you look at the x-rays, this is a different sort of view of the x-ray. It's what we call an outlet view, where you see that yellow arrow. That's basically looking at the shoulder coming in from this perspective, and you can see that space, and that's basically where that rotator cuff has to live. And when we get older and move along through life, we can all start to develop these little things called acromial spurs. And that sometimes can pinch on that rotator cuff and lead to lead to the syndrome we call impingement. So how does impingement happen? So you can think of it sort of as an extrinsic or mechanical sort of compression. You've got the rotator cuff getting pinched between the acromion, which is, when you look at that ball and socket joint, it's basically this bone right here. And you can get these spurs that come off the edge here. And also something called the coracoacromial ligament, and then the AC joint. And the AC joint, it's basically where your clavicle comes in and hooks into the shoulder. And as we get a little older, sometimes it can become arthritic, can get bigger, and can pinch on that rotator cuff. So we look here, there's a little picture on the left. That's sort of a healthy sort of setup with a nice healthy blue bursa. On the right, you start to get some inflammation, start to get some pinching, and then that rotator cuff starts to get inflamed and kind of beaten up. So the way I sort of think of it, it's sort of a continuum, right? It's not like a static one-time thing. You get impingement and then it goes away. It kind of it's a progressive thing. So you get some pinching of that rotator cuff. That leads to some bursitis, some inflammation, which then leads to some partial rotator cuff tears. And then sometimes those partial rotator cuff tears can then progress to the full thickness tears, which is obviously what everybody is concerned about. When you start to get the impingement-like symptoms, probably the most common complaint is you get this dull, aching sort of pain, and it kind of radiates down the shoulder. And I've had numerous patients come in and go, "Doc, it's not my shoulder. It's not my shoulder. I promise you, it's my arm or it's my bicep." And they'll come in and they'll hold here. But what that is the nerves that lived sort of deep in that shoulder joint, I tell people, are cross-referenced with the nerves that come down your arm. So what you're experiencing in the shoulder, you feel come down that upper arm. Most of the time it'll stop at the elbow. If it goes down past your elbow, then we got to start thinking of, is this truly shoulder, or is it shoulder plus something else? You know, pinched nerves in the neck, or you getting some tennis elbow? So we have to kind of work through that. This is what I was saying about the pain in my biceps. This is usually what they look like when they come in. And one of the hallmarks is it's worsened with overhead activities. And a lot of times people say it doesn't really bother me if I'm just kind of sitting still. Let's see. So when you're doing an overhead activity, you're bringing that shoulder up, and what you end up doing is as you bring that shoulder up, you can imagine pinching that rotator cuff beneath that bone. So how do we treat this? Number one, it's always non-surgical to start with. It's always first line. You treat it with anti-inflammatories, ibuprofen, Aleve, those sorts of drugs to try and reduce the inflammation. Therapy, I think, is a mainstay. Really important. And what you're trying to do is correct some of the bad mechanics. People start to develop bad habits when they have shoulder pain. They hike their shoulder. They start doing things which are compensatory, which help on the front end, but on the back end, they end up causing more problems. And then we try and talk about activity modification. You know, people that are gym rats, CrossFit people, we try and talk to them about, like, listen, you got to change up how you're working out so that you're not beating yourself up. But sometimes it's harder to work through if a person's, in overhead labor, somebody who's swinging a hammer for a living. It can sometimes be hard. Another line of treatment is injection. Usually not our first line. In my hands, I basically, if people are having just god-awful night pain where they just can't sleep, I think injections can be helpful for that. But I try and avoid the injections if I can. So when we get through all that, when do we need to consider doing something different? And that would be surgery. And basically, I make patients, you got to kind of work through the process before moving to surgery because, surgery obviously involves, risk. I always tell patients, listen, we'll always get an MRI beforehand. We'll kind of know what's going on. I tell them there's absolutely no rush to go in and get the surgery that we're going to talk about in a second. As long as you keep stretching your shoulder, keep the stiffness out of it so you don't get a frozen shoulder, like Dr. Mostak's going to talk about, there's really no rush. I tell people, maybe 10 or 15% of patients, despite their best efforts, anti-inflammatories, injections, therapy, we just can't get you better and you need that reset, and we got to change your anatomy. So how do we fix it? So what we're going to do is we're going to trim away the anatomy that's causing the problems. Universally, this is done arthroscopic now. In the past, we would do this big open incisions, saw blades, that sort of thing. Don't do that anymore. We try and use the camera and the scope tools for everything. This is just a generalized picture, and what we end up using is the camera and a little thing called a burr, which you can think of as just like a rotary tool, and we use that to buzz down and clean up the undersurface of that acromion and take away that spur that I showed earlier. When you look here, this is just kind of a sequence of pictures. That's sort of a start of it. You can see that spur kind of hanging down. This is kind of like the halfway shot where you can see what's being resected, and then when we're all done, we've got a nice flat surface. The spur's been resected, and now we've opened up that space, and if you see the sequence as you go along, you kind of can imagine that subacromial space getting opened up, and that rotator cuff now has some room to breathe. The rehab is very straightforward, assuming that we don't have to address anything else. We don't have to mess with your biceps or treat potentially a rotator cuff tear at the time. It's basically just a sling for some comfort. We try and get you moving right away so you don't get stiff. Recovery is variable. Everybody is different. There are some people that bounce right back. I use my mentor, Dr. Connor, as like the perfect case scenario. He had surgery on a Friday and he was operating on a Monday. He's a little crazy, but that is a little atypical. But I tell people, don't be surprised if it takes you a few weeks to kind of get over it, and you'll notice your shoulder for a while, but hopefully by 3 months, everything is just kind of melted away, and you're back to doing the things that you want to do. And that just goes along with this. Some need more, some need less. So that was impingement, and now I get tasked with talking about rotator cuff tears. So in some level, you can think of rotator cuff tears as sort of a continuum of impingement. If the mechanical abrasive sort of situation progresses, you can sometimes progress to a rotator cuff tear. So I'll briefly touch about just a little bit of the anatomy, a little bit of the function, sort of prevalence, causes, and then how do we fix it. The anatomy, as Natty mentioned, it's basically comprises 4 muscles. You have the supraspinatus, which is the muscle on top. Might be a little difficult to see here, but it's this muscle on top here. It basically lives below the acromion. You have a muscle in the front called the subscapularis, and then you basically have basically the 2 muscles in the back, which is the infraspinatus and the teres. And then what do those muscles do is they basically sit there to balance that golf ball on the golf tee that Natty was alluding to. You can think of it as the dynamic stabilizers. They basically balance the shoulder to suck that ball into the socket so that it can't pop out. And when you go to initiate motion, it basically pulls that ball into the socket and allows you to start moving the shoulder. This is just kind of a picture kind of demonstrating that. You can see the pull vector of that rotator cuff pulls the ball into that socket to keep it nice and stable. And it allows us to initiate motion, so as you start to lift up and raise up that hand, it allows us to give us the high five, which I guess we're not allowed to do anymore because of the virus problem. So what is the prevalence? So it's kind of all over the place when you read our literature, but I think a general rule is that if you're over the age of 60, you have about a 30% chance of having a tear of that rotator cuff and really being asymptomatic. Usually they're small tears, and we're not going to chase something that doesn't hurt. By the time you get to 70, though, it really goes up, and there's some reports as high as 65%. But I put this guy smiling up here because just because you have that rotator cuff tear doesn't mean we necessarily have to chase it, especially if you're not having symptoms. So what are the risk factors? Age is obviously a huge risk factor. I like to use the analogy that everybody starts off with a fresh pair of jeans. You start off with the jeans, you start to trip and fall, and as you trip and fall, you kind of scuff the jeans a little bit, but they're still, holding strong. And then by the time you get up there in age and take a few laps around the sun, you've got these big holes in your jeans, and that's sort of what you can think of as the rotator cuff tear. Another risk factor, a big one, is smoking. It's pretty much everybody knows smoking's bad. Don't do it. Okay, that's my public service announcement. High cholesterol, which is an interesting one, and the thought behind that is that it affects the blood supply. Blood supply is everything to our bodies, right? And so the little microvessels that are coming in, if you have high cholesterol, it can interrupt that blood supply. Also, a family history. If you have a mom and dad that's had a rotator cuff tear, make sure to come and see one of us because you're probably going to need some help down the line. What other causes? Traumatic. So falling down, right? You slip and fall, you can injure yourself. Dislocations, anybody over 40 who gets a dislocation is a big risk for a rotator cuff tear. We talked about chronic, just kind of as we get a little bit older, changes in blood supply, those sorts of things start to affect the tissue and can lead to breakdown, and the bodies don't have the capacity to repair. So these little micro trauma and micro insults we get through the day tend to add up. And then we talk about the chronic impingement, sort of what I was talking about before. You get this chronic pinching, which leads to the bursitis. You get the partial tears. The partial tears then progress. Sort of the jeans analogy. So what are the symptoms? So a rotator cuff tear, especially if it's sort of a degenerative or progressive, very similar to impingement. It's sort of on that spectrum. You get the radiating pain. Weakness is a big component. As you start to get that tear and it starts to progress, you can't initiate that motion. Sometimes we'll unfortunately see patients come in that have this big, what we call massive tear, and they have what we call pseudoparalysis. They can't initiate motion, and that arm just won't go up. Night pain, I think, is a big one. It usually sort of pretends or sort of shows us that the patient may have a a bigger tear, the ball is kind of moving around a little bit. It doesn't have that dynamic stability. It tends to really bother people at night. And that's what I tend to see people coming in and saying, like, listen, I do fine during the day, but I can't sleep. I cannot sleep. And they just toss and turn all night. And they're just exhausted by the time they come in. So how do we treat rotator cuff tears? Well, there is a role for non-surgical treatment. You know, you have a patient that's older, you know, not very active, not having a ton of night pain. Just because you have that rotator cuff tear, a lot of times we can try and treat you with some therapy, anti-inflammatories and that sort of thing. In addition, you know, as we get older, we start having medical problems. Patients that have lots of medical problems, you know, probably going to try and treat that without surgery. So how do we treat? Very similar to the impingement, like I talked about. So we're going to do the anti-inflammatories therapy, activity modification. You know, try not swinging the hammer over your head. Everybody wants to know about injections. Reason why I put plus minus is a little different sort of thought process than impingement. Is that if you're thinking about that you're going to want to fix somebody at some point, you really don't want to be giving that person a lot of steroid injections. It has a risk factor for infection. It has a risk for damaging the tissue, so that it has an increased risk of falling apart after we fix it. So if you're thinking about fixing it, or if you're discussing with your doctor and they're thinking about fixing it, don't be surprised if they're a little hesitant to like bridge you with a steroid shot. That's kind of what I was getting at, is that the key takeaway is that you just don't want to do repeated shots if we're planning on operating. So when do we need to operate? Definitely young, active patients with a traumatic tear. If it's a traumatic tear, we're going to talk to you about fixing it. Or if you have the patient who's a little bit older, has failed the conservative treatment, having the night pain, just miserable, and understands the risks of surgery with the understanding that, that we have a good chance of making you better. I call this kind of the rule of 50s. 50% of people that have tears that are asymptomatic, in 2 to 3 years, those can transition to become symptomatic. Usually it's because the tears have gotten a little bit bigger. And when you look at symptomatic tears, 50% of those are going to progress by 2 years, and bigger tears progress faster. So, you know, if we see somebody with a big tear, it's a little bit retracted, we'll go to you and say, listen, there's no sense of emergency, but, you know, there's a sense of urgency that you may want to address this sooner rather than later. Typically, we have an MRI, and this is a classic picture of a tear. You know, this is not retracted. You can see the small little white bridge right there, and that's basically where that tendon has pulled off of the bone. So how do we fix? So I would say almost universally we fix these arthroscopically. There are some small instances, you know, maybe once or twice a year I'll have to open a shoulder because it needs to be done open. But almost all these we can get arthroscopically. The way we fix it is very similar to the impingement pictures we showed. There's a camera that goes into your shoulder. You have multiple poke holes. And then there's a bunch of techniques, which is a little outside of the scope of what we're talking about here. But most people use anchors and suture. And we basically drive those anchors into the bone, and then we pass the suture through the tendon, and we sew that tendon back down to the bone. And what we're trying to do is get those edges of the tendon with the blue arrows back down to where they need to be. These are just a couple of pictures of some anchors, one before it goes in and one in bone. And then when we start with this, what we're trying to end up with is something like this, where we've sewed that tendon down to the bone. The rehab definitely more involved than the impingement. It's outpatient surgery, usually go home the same day. You're in a sling anywhere from 6 to 8 weeks, depending on how big the tear is, what the tissue quality is, other stuff that we had to do in your shoulder at the time. Therapy, and when I say 3 to 6 months, it's not that you're not going to continue to do therapy for quite a while. This is more the supervised therapy. We're actually going and seeing someone. Some people by 3 months have kind of knocked it out. They know what they're doing and can kind of progress. Some people need that supervision for 6 months, and I've had a couple of patients just want to go back for some follow-up for up to a year. Now they're not going every week. They're going, maybe once every 2 months and just getting, okay, I'm ready for the next set of exercises. I always tell patients it's more frequent on the front end of surgery. We're trying to keep you from getting stiff, trying to maintain your motion, and then you have less supervised visits on the back end as you get more and more comfortable with your shoulder. I tell people you're going to continue to improve for a year. You're going to be pretty miserable that first day of night after surgery. We usually make you wait a week to come back and see us because otherwise you punch us in the face because you're not. It's a little bit painful. But after that first week and you kind of start getting through it, it gets better and better, and you'll continue to see improvement for up to that 1 year mark. Stiffness is the enemy. We don't want your shoulders to get stiff, and that's what we're always trying to fight as we go along. Sort of think of myself as like a cheerleader when you guys come back to clinic. And I always use the analogy, the tortoise versus the hare. This is not one of those things where we want you coming out of the sling and moving it as quickly as possible. It's a balance. And so if you try and rush through things too fast, you don't give a chance for that tendon to heal back down to the bone, and then we're no better for having had this surgery. And then I always sort of use the analogy, surgery is the easiest part. It's rehab is what makes the difference and makes us all look good. And I guess we're going to do some questions afterwards. Thank you.
All right. Thanks, Dr. O'Neill. That was a great review on a really big topic. So please let us know what questions you have. Either write them down or submit them online, and we're going to come back to rotator cuff and impingement syndrome a little bit later tonight so we can answer all your questions. Okay, next up, though, we're going to have Dr. Mostak. He's going to talk about frozen shoulder. Dr. Mostak did his residency orthopedic training upstate New York. He did his fellowship in sports medicine at the Houston Clinic, and he has a practice in the Concord area.
How do I cue up the next one? All right, great. Thank you, Dr. Hammond, for the introduction. It's really an honor to be with you tonight and to be asked to come and speak to you. Hope to provide just a few minutes and a few specific useful pieces of information about frozen shoulder, which is, as Dr. Hammond alluded to, we're on to the ouch, my shoulder is too stiff part of the evening. So we're going to get right started. Again, I'm Dr. Mostak. I'm in practice up at Concord, up in Concord at our Concord location. So it's good to be down here. A little bit about frozen shoulder. The most common term that you'll hear it described as is frozen shoulder. In medicalese, it's adhesive capsulitis. It can really encompass more than one different type of shoulder stiffness. Predominantly what we're going to talk tonight a little bit about is primary adhesive capsulitis, which is the type that just kind of occurs out of nowhere. It just, for no good reason, your shoulder starts to get stiff. There is secondary adhesive capsulitis, which can occur secondary to an injury, such as a fall. For instance, say you had a sprain or a fall at work and you perhaps favored your shoulder, maybe wore a sling for a week because the urgent care told you to, and started to get a little stiff, and you can develop a secondary adhesive capsulitis after an injury. You can also get stiffness in a similar vein after surgery. So Dr. O'Neill put it very succinctly that we don't want our shoulders to get stiff after surgery is performed. So we want to balance, we want to allow healing, but if we get off of that balance, we can get a shoulder that becomes stiff and adhesive in the same manner. So that's something we have to be careful about. Tonight, I'm just going to speak predominantly about primary adhesive capsulitis, which again is insidious or for no good reason, idiopathic. So what are the demographics? We suspect it has a prevalence of about 2% in the general population. Sorry to pick on the ladies here, but 70% of the time it's women. Usually we look for it in the ages between 40 and 65, and there are a few risk factors. You see diabetes, thyroid problems, hypothyroidism, and autoimmune disease. So patients often want to know, get frozen shoulder, what's the natural history of this? What's going to go down? What's going to happen? So the upshot is that it's self-limiting, meaning that it's a self-limited disease. So if you get frozen shoulder, you're most likely to pass through a series of stages, which we'll talk about in a minute. However, at the end of the day, it's expected to resolve on its own. The kicker is that it can take some time, and as you see here, 12 to 24 months. That's a pretty darn long time. That's not something that most people often want to sit around and wait for that to happen. It's like slower than Congress, you know? So, and even after 2 years, in 10 to 20% of the time, stiffness can persist beyond that 2 year period. So another good question is what's the overall history or what causes this? And we don't really know exactly. We know at the molecular level and the cellular level what the pathology seems to be, but exactly what's going to cause my neighbor to have frozen shoulder and myself not, we don't know exactly why that is. And as a corollary, the exact treatment is not entirely defined. I think you'll find different physicians that do different things, and I can tell you a little bit about what I do, and we'll touch on that briefly at the end. So, pertinent anatomy, it looks like my slide. Here we go. Just a general kind of slide that shows a good balance of the anatomy. This is the rotator cuff, the muscles that surround it. I don't know if my laser point's working here. The muscles that surround it won't shoot the screen, but these are the rotator cuff muscles. That long biceps tendon, which is a kind of a adjacent cousin to the rotator cuff running right alongside. And the layer that I'm interested in to talk to you about for this purposes of this is a deeper layer, and it's the capsule. So what is the capsule? It's kind of a thick, leathery collection of ligaments that surround the entirety of the shoulder. It's kind of like a balloon that your ball and socket exists inside. There are different components of the capsule, and particularly the component of the capsule, or the ligament in particular that we're most interested in, is called the rotator interval, which exists between the supraspinatus tendon, which Dr. O'Neill mentioned, and then the anterior rotator cuff or front rotator cuff tendon called the subscapularis. In between those two tendons, there's a portion of the capsule that most often is the first involved portion that starts to get inflamed and subsequently stiff in adhesive capsulitis. A little bit more of a cross section, so you can think of this capsule in a different way. This ligament here, kind of drooping down like a teardrop, that is the part of the joint capsule. And in someone with severe adhesive capsulitis, we don't usually get MRIs, but when we do happen to get one, you'll often see that normally low-hanging space that's nice and flexible, you'll see it tightened or even absent. Just another cutaway here. So again, looking at it from the side, you can imagine a side view x-ray, except now this is soft tissue. The rotator interval is the space between the subscapularis tendon and the supraspinatus, and one of the structures that's contained within it, two structures, the biceps, the long biceps, and the superior glenohumeral ligament. Those are two structures that exist, again, within that space. So we think the genesis or the essential lesion of this is in that rotator interval. So talking about some of the clinical stuff. If you WebMD this or look online, you'll see most often you'll come across this, which is a description of 3 different stages of frozen shoulder. The first is kind of the painful stage, where things start to get inflamed. Patient would often report night pain. Night pain is a classic symptom across multiple shoulder conditions. If it continues to get worse or doesn't, you don't feel better, you can go on to a frozen or adhesive stage. So that's broken out down between kind of a freezing or getting more stiff and then a frozen stage where your shoulder is stiff and you're just kind of living with it. So the shoulder becomes progressively stiff, worsening range of motion, worsening night pain. But by the time you get to being frozen, you will still potentially have symptoms, but it usually doesn't worsen during that time. And then finally, towards the end of the natural history of this problem, we get to the so-called thawing stage, during which the shoulder range of motion starts to improve. And it's, again, the key point there is that it may take a long time, very long, sometimes longer than most people are willing to put up with. Pre-adhesive stage, usually on average 0 to 3 months, but this is just a rough guideline. The patient will have pain with active and passive range of motion, but they usually typically have motion that's pretty well maintained. And then any number of things can throw a person into this pre-adhesive stage. They can just start to have it, or an injury, or even post-surgical problem. So if we were to examine someone under anesthesia, for instance, if someone was asleep and we had the opportunity to manipulate the shoulder, we would find that there's really not too much loss of range of motion compared to what is normal. If we were to look inside someone's shoulder arthroscopically, we might see something like looking like this. This is the, down here in the very corner is the ball. This is the subscapularis tendon, which is that front thickest rotator cuff tendon that I explained. And then this is that rotator interval. We're going to look in here and you see this kind of beefy red inflamed tissue. So that is not normal. That is that interval that's injected with a lot of vascularity and hyperemia, inflammation. And so that's what someone that might look like, that's what someone's arthroscopic view might look like if they're starting to get a frozen shoulder. So now on to the freezing stage, 3 to 9 months on average. Someone's going to have chronic pain with active and passive range of motion. Again, you still might find that their exam under anesthesia, you would find that their exam under anesthesia is identical to when the patient is awake. And the patient by that time is going to have reduced active and passive range of motion, meaning that how much you can move it and how much I can move your shoulder for you are similar. By the time you get to the frozen stage, this is kind of the end of the plateau. The patient would, again, be likely to have less pain, except at the terminal end of range of motion. If you were to manipulate their shoulder, it would feel rigid. It's almost like a stiff tether that suddenly stops the range of motion exam at a certain point. And then the thawing stage. It can take the longest, 15 to 24 months after the onset of the problem. Pain, again, is going to be minimal, and you're going to start to feel an improvement in range of motion. So how do we make this diagnosis? This is one shoulder condition in which the diagnosis is almost entirely clinical. If you were to come into one of our offices, you might tell us that you're having pain and maybe some stiffness. We would examine you, check the range of motion, and the key point is that, again, your range of motion actively is going to be diminished, but then similarly, your range of motion when we try to move you, with just passive range of motion, is also going to be diminished. There is a role for x-rays. I think most of us would typically get x-rays just to rule out any other causes of what could be causing stiffness, such as a spur that Dr. O'Neill alluded to. We'd want to make sure we diagnose those other problems. Again, shoulder being a complex joint, there can be more than one cause of pain. An MRI, typically that's less often used. Again, if there's an unclear diagnosis or we're strongly suspicious of a concurrent pathology, like maybe there's a rotator cuff tear in addition to adhesions. What are our treatment options? Similar to rotator cuff pathology and impingement, the predominant treatment is non-operative. We almost always start with non-operative treatments. Modification of activities. If you're doing something that's repetitively that's causing your shoulder to hurt or become inflamed, we might ask you to stop that. Supervised physical therapy or a home-directed physical therapy program. Oral anti-inflammatory medicine, and then cortisone injections. And in my practice, cortisone injections play a little bit bigger role in this particular problem than perhaps some of the other shoulder pathologies. If we get to a point where everything's just failed to work, having no improvement or progress, you're miserable, you're beside yourself and frustrated, there are some operative options. We could proceed to the operating room, again, usually in an outpatient setting. Closed manipulation or anesthesia, where simply there is no cutting. The shoulder is simply manipulated once the patient's awake, often with a regional nerve block performed by the anesthesiologist. Or we can combine the manipulation with a lysis of adhesions arthroscopically. And that is performed with the camera, with the arthroscope. What we go in and do is actually those thickened bands of tissue, especially in those spots I showed you earlier. We use most often a special cautery probe to release those bands of tissue. And then once the releases are performed, usually we find that the manipulation can be performed after that, and we can get the shoulder to move. So typically, preceding the manipulation with arthroscopy is felt to be safer. It is less risk of a iatrogenic injury, which means that during the surgery, something else gets injured while we're trying to manipulate the stiff shoulder. So non-operative treatment, physical therapy does play a role. Cortisone injections, I believe, do play a role in this process. Preceding therapy with an injection will allow the patient to have better tolerance to the therapy, which tends to be intense as we're trying to stretch out the shoulder. There has been at least one study that's shown, it was a randomized placebo-controlled trial that showed a steroid injection plus physical therapy was more effective than just physical therapy. And then the injection, something we can do very simply in the office. It hurts, it's an ouch for a few seconds, but typically what we try to do is inject both the joint space, the ball and socket joint, and the bursal space, which contains the rotator cuff. So with one injection, we can typically do it in such a way that we hit both of those spaces. Operatively, manipulation or arthroscopic lysis adhesions plus manipulation. Surgery center, outpatient. And I'll usually have my patients try to go to physical therapy the exact same day they have surgery. They're a little groggy, but I'll have them have their surgery in the morning and try to get them over to the therapist in the afternoon. So the physical therapist can start to manipulate and work with that motion that we've now gained while the nerve block is still in place. Here's a typical shoulder arthroscopic surgery setup. This is not my particular OR, but you can see the shoulder is suspended in such a way that we can manipulate it and we can use the camera to look inside. Here's a little bit of a surgical procedure being performed. This is that probe that I mentioned to you, and what we typically do is release this capsule just adjacent to the shoulder socket. In order to minimize the risk of injury, we stay right adjacent to the socket and release those painful thickened band tissue with a electrical instrument. So kind of getting to the end of it, here's kind of what do I do if I see a patient that comes to me has adhesive capsulitis. Usually what I'll do is discuss the patient, discuss the pathology with them in detail. I like to start with a cortisone injection. I'll do it inside the joint, and I'll repeat it up to 2 additional times at once-a-month intervals. During that time, I'll send the patient off to do a home physical therapy program or supervised physical therapy depending on the patient's preference. We'll see them back. We'll give them about 3 months of non-operative management, see how they're doing. Does the stiffness persist? If so, if not, great, on you go with your life. If this stiffness is persistent, we have a couple options. I'll give them the option to continue with the stretching for as long as they want, usually at home, but without any additional injections. Or if they're fed up with it, if it's something that's just, again, the patient usually is very candid about being at the end of the rope with their symptoms, we can move on to surgery. And again, that immediate postoperative physical therapy, I'll ask the patient to go to physical therapy right off the bat. And so you can see, as with most things that you'll speak to myself and my partners about, the decision process is a shared decision-making process. It's something that we talk about and we decide what's the best next step for you, not some specific cookbook protocol. So, in summary, frozen shoulder adhesive capsulitis, 2 to 5% chance or 2 to 5% prevalence. Usually more common in females and males. Usually it's the non-dominant arm. Some conditions that we talked about earlier, diabetes, hypothyroidism, and autoimmune conditions can predispose someone to having this. Good news is it's usually self-limiting. The bad news is that it can take a long time for that self-limiting process to work itself out. And if we do treat, either in the office or during with surgery, your treatment plan is, of course, going to be tailored to your individual needs and your expectations and how fast you want to go and what your expectations are. So once again, thank you so much. This is the Concord office off of right near Atrium Cabarrus. It's we have subspecialty care in sports medicine, shoulder and elbow, total joints, foot and ankle and hand. So if you're up in that area or reside near there, please come by if you need anything. But again, it's delighted to be here with you, and thank you very much.
All right, thanks, Dr. Mostak. It's amazing how often frozen shoulder gets mistaken for rotator cuff disease, and we see that all the time. And I hope you got a little bit of an idea how much different the actual disease process is and how treatment is much different too. So great. Well, we're going to go on to our last little talk, and then we'll have plenty of time for questions. So next up is Dr. Shad Schifrin. Dr. Schifrin did his orthopedic training at the University of Utah, and then he did his shoulder fellowship down in Texas with two guys named Butch and Buzz. Take that for whatever it's worth. And he's partners with me. We're both shoulder specialists at the Shoulder and Elbow Center in downtown Charlotte. Dr. Schifrin?
Thanks, Natty. It's a pleasure to be here. Great to see such good turnout for everybody here, and also for everybody that's live streaming with us. We're glad to have you on board with us. We'll get this going.
Yeah, we'll get it going.
Perfect. As Natty said, I practice with him and 5 of our other partners at the downtown Shoulder and Elbow and Sports Medicine Center in downtown Charlotte. And I get the pleasure of talking about probably my favorite topic, which is shoulder replacements. We're going to talk a little bit about when and why. So when we talk about shoulder replacements, there's really 2 main types of shoulder replacement. There's anatomic total shoulder replacements, which basically are just replacing the ball and the socket, replacing the ball with a metal ball and the socket with a plastic socket or polyethylene socket. And then there are reverse total shoulder replacements. And when I mentioned this to the patient, they wanted to know if I was going to put their arm on backwards when we did their shoulder replacement. It's not really what it is. It's we're just reorienting the ball and the socket joint to try to cope with a very specific type of problem in the shoulder. And we'll talk a little bit about that. But as you can see, the ball is implanted up where the old socket used to be, and then the socket liner is attached to the top of the humerus bone. So kind of get an idea of what that really means when we use that term. Things we want to cover in this talk are talking a little bit about the common diagnoses, reasons why we need shoulder replacement. What are some alternatives to shoulder replacement surgery? Talk just a little bit about an overview of the surgical procedures, and then really decision making of what type of replacement is appropriate for each patient. And so again, I think you can't really talk about replacing the shoulder unless you talk a little bit about normal shoulder anatomy. And you've already heard the other guys talk a little bit about this, but we're specifically really focused on the ball and socket joints. So the ball part of the shoulder is the top of the humerus, and it sits in the socket, which is really just the outermost part of the shoulder blade. And then as Natty brought up, and Scott gave a very nice talk about the rotator cuff, we have the 4 rotator cuff muscles that go completely around the ball and socket joint, and they're absolutely crucial for the stability of the shoulder. And so that's, as you'll see, one of the primary deciding points of shoulder replacement surgery is whether or not the rotator cuff is intact, because it makes a huge difference on what type of shoulder replacement we can perform. We want to first talk about anatomic shoulder replacement. And by far and away, the most common diagnosis that we do shoulder replacements for is common run-of-the-mill osteoarthritis or wear and tear arthritis of the glenohumeral joint. And this picture shows on the right side a normal shoulder with nice joint space in here, where you can imagine there's nice thick cartilage on both the ball and the socket that give nice cushion, allow for good mobility. And in osteoarthritis, arthritis is really a condition where the cartilage is broken down and worn down. So you start to develop wear and tear of the cartilage, and then there also is a biomechanical process that goes on that starts to cause destruction within the joint. And so what we see is that the joint space decreases to the point where you hear people talk about bone-on-bone arthritis. Well, that's literally when there's no more cartilage left and you start feeling the bone rub against the bone. We also see these classic bone spurs that form on the bottom part of the ball down here. Some people refer to them as the goat's beard osteophytes or spurs because they hang down off of the ball. We see some cysts that form because some of the joint fluid, when the cartilage is not there, the joint fluid can seep into the bone and form these little cysts. And also you can see some sclerosis of the bone because as the bone surfaces rub together, it makes that bone really eburnated and hard. And so this is kind of a classic x-ray we'd see for somebody who comes in with osteoarthritis of the shoulder. Other less common diagnoses that we do anatomic shoulder replacements for include rheumatoid arthritis, which rheumatoid arthritis we still see in the population, but because the medications that are designed to modify the rheumatoid disease process have gotten better and better, fortunately we're not forced to operate on as many of these rheumatoid arthritic shoulders as we used to in the past. Avascular necrosis is a condition where the blood supply to the ball part of the shoulder can get disrupted and can cause some collapse to the joint. And then also post-traumatic arthritis. So sometimes the shoulder can become arthritic and wear out as the sequelae of an injury. And probably the most important take-home for anatomic shoulder replacement is this operation does very well for these arthritic conditions if the patient has an intact rotator cuff. So you really need a good functioning rotator cuff for this operation to work. The presenting symptoms and complaints of shoulder arthritis, pain is probably the biggest one. And as you've heard with both frozen shoulder and rotator cuff, night pain is very common. So that's usually the tipping point for my patients when they say they're finally ready to have their shoulder replacement, is when they just cannot sleep at night. It wakes them up multiple times and they're not getting good rest. But also stiffness and decreased motion. So besides frozen shoulders, shoulder arthritis is another very common reason for loss of motion in the shoulder. And so patients come in and say, I can't put my coat on anymore, I can't get my reach back behind my back, I can't put my belt on, I can't get to my wallet. Those are very common things that we hear with shoulder arthritis. The other thing is with arthritis that distinguishes it from the other conditions is the crepitus and the noise. So people say, I move my shoulder and I can hear it. And literally my wife can hear it popping and clicking when I move the joint, and that's because of the rough surfaces within the joint. So treatment options, we have a lot of the similar options that we try on folks when they're early on in the disease process, when we're trying to avoid surgery or put off surgery as long as possible. And these include non-steroidal anti-inflammatory medications, especially early when the arthritis is present. Physical therapy can play a big role. If we can get folks onto a stretching program, sometimes the motion can improve and the symptoms can stay at bay for a little while longer. We do use cortisone injections into the joint, and cortisone is a type of steroid. It's a corticosteroid that really in its basic form is a powerful anti-inflammatory. So we try to put the medicine right into the joint and see if it will help calm down some of the inflammation that causes pain within the joint. We don't do a lot of injections. We try to be sparing with the injections, but especially for somebody who's really in a lot of pain and not at the point they're ready to have surgery, an injection can be a Band-Aid or a bridge to try and buy them some time. I always tell my patients, don't expect cortisone is going to fix the underlying problem. It's not going to bring the cartilage back, but it's to try to mitigate some of the symptoms. And then, one of the hot topics you hear if you go online and even reading the newspaper are some of these biologic therapies and stem cell injections. And we're currently at OrthoCarolina becoming involved in some of the research side of some of these therapies, because the problem right now is there's really not any good science that shows that injecting stem cells into an arthritic joint such as a shoulder really does anything or gives any benefit. And as some of you may have experienced or looked into, there's a lot of clinics around even the area in Charlotte where you can go and have stem cell injections performed and pay a lot of money for them too. But really at this point, there's not really a lot of science or evidence that shows that it works. And so we all hope that at some point we may be able to find the magic answer for some of these biologic therapies. But at this point, if patients ask me about it, I don't recommend it. That's something we could talk about at the question and answer session after. From a surgical standpoint, early on in the arthritis process, before it's really bone on bone, you can go in minimally invasive arthroscopically and kind of do a cleanup procedure in the joint, smooth off some of the rough cartilage edges, release some of the areas that are tight and have some benefit, but it's a very small part of my practice. I think there's only a select number of patients in the early arthritis process that may benefit from it. And then shoulder replacement is really the go-to operation for when the arthritis gets bad enough and the symptoms are bad enough to warrant surgical treatment. And shoulder replacements can either be done with a total shoulder replacement, replacing both the ball and the socket with a polyethylene socket, or you also in some situations can do just a partial replacement, just replacing the ball only and not the socket. But there have been several well done studies that have proven to us that the pain relief that you get from a full shoulder replacement is better than a partial replacement across the board. And so this would be just a typical case of a patient that comes in the office, has this X-ray that shows, basically from looking at, compared to the normal X-ray, this shoulder has no space between the ball and socket joint. Here's this bone spur, osteophyte down at the bottom of the ball. If we look at an X-ray taken at the opposite projection, it shows again the ball of the shoulder sitting right against the socket. And in a lot of these cases, just like this X-ray shows, over time the tissues in the shoulder get tight and it actually pushes the ball toward the back of the socket and starts to cause an abnormal wear pattern in the back part of the socket. And so this is a patient who probably the only option to give them relief is a shoulder replacement, and that's exactly what we did in this case. I want to shift gears and touch on the reverse shoulder replacements, which interestingly have become, for many of us that do a lot of shoulders, almost half and half of the replacements we do nowadays have gotten to the point where we're doing that many of the reverse type shoulder replacements. It was an operation that was described in France, and the French have a little over 20-year track record with it. It's been in the United States for about 16 years because the FDA process lags a little behind our European colleagues. And it's really, I would say, probably been the one operation that's revolutionized shoulder treatment in the last 15 years. The common diagnosis we use reverse shoulder replacement for are patients that have massive, irreparable rotator cuff tears, or tears we just have gotten so bad that we cannot fix them. And then the next progression of that is this condition called rotator cuff arthropathy, which is a chronic arthritic condition that results from the abnormal forces when you have a rotator cuff that is not repairable. So this is a picture of the ball of the shoulder on an MRI. You can see what was left of the rotator cuff is way over here. There's no rotator cuff over the top part of the ball. And when the tendon gets this far retracted, there's just no way we can grab the end of that tendon and pull it back over to the ball and fix it. And so these patients end up with a lot of functional limitations and pain, and that's the reverse operation was designed for exactly this type of problem. The progression of rotator cuff arthropathy happens because you also lose the support of the rotator cuff holding the ball down into the socket. And so when that rotator cuff's gone, the ball migrates up out of the socket or to the top of the socket and eventually starts rubbing right against that acromion that Scott talked with you about and starts to deteriorate the cartilage. And so it's almost a secondary arthritic condition that happens because of the abnormal forces from the massive rotator cuff tear. And the presenting symptoms, of course, pain, night pain, very common. And as was mentioned previously in Scotty's talk, this phenomenon of lateral arm pain is very common in this scenario. So I get the same thing. It's not my shoulder, it's my arm, mentioned in the office a lot. But even worse in these situations than the osteoarthritic cases is loss of function and weakness. And we use a term called pseudo-paralysis, where if we ask a patient to raise their arm, they have a severe case of this, they literally try to raise their arm and it just doesn't raise. So, and it's because the rotator cuff doesn't have that ability to compress the joint and allow the deltoid muscle to raise it. And so the deltoid muscle fires trying to raise the arm and the shoulder slides up, but it doesn't move. And so this is a very common finding that we'll see at the end result of this. And they get the same type of crepitus and noise within the joint. We go along the non-operative treatment, again, same as with osteoarthritic cases. Arthroscopic treatments for this problem. In the early phase with some of these irreparable rotator cuff tears, there now are some arthroscopic options to try to salvage a shoulder and avoid a replacement. But the end operation for these is the reverse shoulder replacement, where we put the ball component at where the socket is, and the socket is attached to a little stem that still goes down in the humerus bone. And so this is, again, just an x-ray of what it looks like. It's got a stem that goes down inside the humerus, just like the anatomic replacement, but instead of the ball at the top, we got this little tray, and what you can't see in between is a polyethylene liner that the picture shows. And then the ball actually is fixated into the scapula, where the old socket used to be, with screws. And so the socket holds it together, and you also have the effect of the deltoid muscle that would be on the outside out here that help to squeeze that joint together and hold everything in place. Why reverse? Why did they design it this way? The biggest issues were to try and restore stability. So instead of the ball sliding up out of the socket, if you flip the ball around and put the socket piece down below, it gave the shoulder back a stable joint. It also changed the mechanics in the shoulder. It medializes the center of rotation of the shoulder. It sort of distalizes the lever effect on the deltoid muscle. And the deltoid muscle in these cases is normal. So by changing the mechanics, it allows the deltoid muscle to take over the function of raising the arm. So you can see a patient that has that pseudoparalysis. They have this operation, they literally can get the ability to raise their arm completely over their head. So the design was revolutionary. And this is a kind of a classic case of a patient that would come into the office. That the x-rays in a lot of these cases do not look as bad as the osteoarthritic cases. They can still have some joint space, but with the rotator cuff that's just completely retracted and not repairable, it leaves us with very few options other than the reverse replacement. So I think that's all we wanted to cover. We'll have plenty of time for a question and answer session. We're going to bring all three of the speakers and Dr. Hammond up. So write down your questions, pass them in, and we'll spend as much time as you guys have questions going over things. And just I'd like to again thank the Experienced Anatomy team for their partnership putting together the event.
All right, can we have our three panelists up here? We got lots of questions. I got them on my phone here. They came in online. We got some here in the room. Okay. So as we get those up, I'll fire away with some of the ones we have already. So Dr. Schifrin, about shoulder arthritis. If somebody knows they have arthritis, when do they know they're ready to consider a shoulder replacement?
Well, I mean, we usually have people come in when the pain reaches a point where it's affecting their quality of life. So affecting their ability to perform activities of daily living, bathing, dressing, housework. And then a lot of times it really is the night pain. And I tell patients that it's never my part to tell them when they need their shoulder replaced, that they will have a kind of a gut feeling when they've reached that time. I certainly try all of the non-operative things if they've not tried it already. Sometimes they've already tried it with their primary care doctor, but trying some medications, we'll try an injection, some physical therapy, see if the symptoms can be alleviated, knowing that the arthritis is not going to go away, but if you can mitigate the symptoms, you can sometimes live with a fair amount of arthritis for quite a long while.
Great. All right, we have three people ask the same question, so we're going to have to hit this one next. And any three of you fire away if you have a good explanation here. Why do these things hurt at night?
We don't truly know, but I think the way I sort of think about it is you have an inflammatory process in the shoulder, and as you try and relax at night and as you start to drift off to sleep, that inflammatory process gets pulled on or tugged on as the shoulder kind of relaxes, the ball sort of settles, and that capsule, the rotator cuff, everything that's inflamed gets kind of irritated, and that's what causes the night pain. That's the best thing I can come up with in my brain. Yeah, laying on it too, yeah, for sure. Especially, in the arthritic situation where you've got a bad joint, the contact pressure when you lay on it could cause some pain as well, especially side sleepers. I don't know, Natty, do you have any?
It is a cruel joke our bodies play on
Yeah.
us. Things that are inflamed and diseased, just our bodies know there's circadian rhythms, or when our body knows it's nighttime, it revs up inflammatory cells, and it tends to cause significant night pain. And I've found actually it doesn't matter how patients are lying. It's just your body knows it's nighttime. Okay. All right, we'll go through, let me sift through these. So, Dr. Mostak, so a lot of people throw around the term frozen shoulder. Oh, I got a frozen shoulder, I did this, now it's, kind of help us understand, is there different types of frozen shoulder, and is there a kind that, you explained doing a capsule release and a cortisone injection, is that applicable to everyone that has stiffness in their joint? Is it different if someone had an injury or a surgery and now they have a frozen shoulder? Help us understand maybe the different kinds of frozen shoulder.
So that's an excellent question. Certainly, frozen shoulder is a term that's out there that most people are familiar with, similar to rotator cuff tear. I think that it's something that shoulder stiffness can come about from any number of causes. Most often, if you think about it, percentage-wise, your shoulder is likely to be stiff not due to classic frozen shoulder, but due to something else, maybe something simply as bumping it into a door jamb, or sleeping on it wrong, and maybe my shoulder is stiff for a few days, or I did too much yard work and my shoulder is sore and stiff. It's easy to think, after a few days of stiffness, oh my gosh, am I getting a frozen shoulder? In reality, that's probably not the case. It's probably just some post-activity stiffness or even delayed onset muscle soreness. The classical term frozen shoulder, as I alluded to earlier, really has to do with just kind of an insidious, like idiopathic, meaning no good reason for it, process that just starts to develop and the shoulder becomes stiff. And again, it's stiff almost irrespective of pain. So in a true frozen shoulder, by the time someone gets to where they are frozen, quote unquote, they're going to be stiff. You're going to be able to raise their arm or have your spouse raise it for you, and it's just going to get to a point where it just will not go any further. And as opposed to pseudoparalysis and rotator cuff disease, it's not for lack of, it's not because the muscle imbalance is causing mechanical inability to lift the arm. It's a check rein. It's a tether that's actually holding the arm from raising. It's a distinct stiffening force. So if you have shoulder stiffness, it's probably not frozen shoulder. It's probably due to something that recently happened. But if your stiffness persists, certainly it's of concern to you, then it's more than certainly come and have it checked out. Myself, my partners who are experts at this, we'll be glad to see you and help you sort through it.
Okay, thanks. All right, we have somebody that's viewing online, and it sounds like somebody that enjoys to do yoga and rock climbing, and they wanted to know, Dr. O'Neill, if you know of any tips or ways to help prevent rotator cuff disease.
So I think a good treatment plan to institute if you're doing a lot of overhead activities is to basically have a rotator cuff program in play. Help keep the shoulder balanced, help keep that rotator cuff strong. As we get a little bit older, I think adjusting the workout routine that you're doing can help to avoid some of those impingement-like issues that we talked about. People who are 40 years old probably shouldn't be trying to bench press 450 pounds anymore. A lot of the patients who enjoy doing a lot of the ballistic CrossFit type activities can be prone to injury, especially if you're throwing lots of weight around, where you can have a traction injury on the shoulder. But I think having just a basic rotator cuff program in your workout routine keeping the shoulder flexible, and then as you start to age, maybe eliminating some of those more risky type of exercises and activities are in your best interest.
All right, hot question. Just
I
came
think
in.
just along that same line, you know, when you go to the gym, you watch people work out, they work out their deltoid, their pecs, their biceps, their triceps, but you don't see a lot of folks in there doing their rotator cuff exercises.
Right.
So we all neglect it.
Yeah.
So.
I tell patients they seem a little silly, but they're very important.
Yeah.
Just add to that one real quick, Pearl, in lifting, a real practical thing. So if you're lifting or doing something around the house, try to do your lifts with the object closer to your body. So if you're lifting something and your arm's fully extended, that creates a longer torque or lever arm and potentially place more strain on your shoulder. So if you can remind yourself, just like bend at the knees when you lift something to avoid back pain, try to keep the object closer to your body when you lift it to avoid strain on your shoulder.
All right, I like this question. I think it brings up a lot of good points. This person said, I had 3 cortisone shots in the last year and tried physical therapy, and they said that they're better during the day, but they still have weakness and they don't have a full range of motion. They want to know, should they try another cortisone injection or should they consider other options? So I guess the question is, what do you see with repeated cortisone injections, and what would you tell this particular person?
I think it depends a little bit on, I ask them, did the injection help at all? If they got an injection and it helped them for 3 months and then the effect kind of wore off, I'd maybe repeat it. If they got an injection and after a week it was no effect, I'd probably be a little hesitant to continue down that road of more injections. The other question always to ask is, where was the injection put in? Because if you have shoulder arthritis and you have an injection around the rotator cuff, like the picture we saw in Scott's talk, it's not going to help because the medicine doesn't get into the joint. Vice versa, if you have a rotator cuff problem and they put an injection inside the ball and socket joint, then that's not going to help a rotator cuff problem because there's 2 different spaces in the shoulder. So depends, I guess is the bottom line answer to that. But if you know the diagnosis and and I've put the shot in myself and it hasn't helped, I don't continue just to do more injections.
Yeah, I think it would be very rare for a 4th injection to cure somebody's problem.
Right.
Yeah, the studies show that the first injection is usually the most successful, and then each injection after that, the benefit from the injection slowly deteriorates over time. So.
And I would expand also that if you're going to somebody and getting repeated injections, but you don't have a diagnosis, that's not a good. We see people come in and they've been treated by their primary care. They've gone to an outside doctor and they come in and, oh yeah, I've had 10 injections over the last 2 years, but they've never had an MRI. They never really had a working diagnosis. Those repeated injections down the road can cause some damage that can maybe hamper our ability to fix you on the back end. So at least in my hands in my practice, I will do 1 injection, maybe 2, without any sort of advanced imaging before we try and figure out and dive in and figure out exactly what's causing your shoulder problem before I would go down another injection.
Okay, we got a lot of questions to work through, but
okay.
I'm going to try and work through them, so my apologies in advance if I don't get to yours, but I'm trying to find ones that I think will stimulate some discussion. This is a good one. This is a retracted rotator cuff tear. Is there a time constraint before the cuff is too far away to fix it? Is 1 year too long to wait?
That's always the issue, right? Yeah, it's so I think we wrestle with this anytime we treat a patient that's got a really big tear. You want to get to big tears, sooner rather than later. That question as to whether or not a year is too long is really hard to say for sure that it's okay to wait for that full year, because we know as time goes on, the tissue changes, the muscles get atrophy, and it has a prognostic factor as to whether or not that repair is going to be successful. The more atrophy, the poorer the tissue quality, the less chance you have for a good outcome. Sort of the way I would sort of think through that.
Okay, good. Dr. Schifrin, what activities could you expect to get back to after a shoulder replacement?
Yeah, that's a great question. And for the most part, a lot of recreational activities are very you can reliably get back to doing. So, around the Charlotte area, there's a lot of golfers. So, you can definitely go back to golf. We have tennis players go back to tennis. Things around the house, gardening, yard work, yoga, exercise. It's always a discussion with some of our patients that have shoulder replacements of the weightlifting, because we do have some folks who want to go back to lifting weights, and I tell them in moderation. I don't tell them they cannot lift weights at all, but they shouldn't be bench pressing 400 pounds. So as long as it's thought through and it's smart, you can get back to a pretty good level of exercise and activity. But what are some other ones?
What about
Fishing, fly fishing,
Bowling. What about bowling?
bowling. I let them bowl.
You let 'em bowl?
Yeah, I do.
I don't. I tell them to use the other side. It makes me
Sometimes use a light ball.
Yeah, it makes me
Light
nervous.
ball.
What about you, Natty? You
you
got the pearls on?
Yeah.
Yeah, I let them bowl.
Really?
I think like push-ups and pull-ups and
Yeah.
dips, anything where you're hanging from your shoulders. I'm not really too comfortable with that.
Right.
And then the more serious contact sports I keep them away from. But I try and let my patients get back to a lot of light recreational sports. And when it comes down to it, if somebody's feeling good and they're confident in their abilities, they're going to do what they want. And so we just want to make sure that they partake in those activities in a smart way. Swimming. Yeah, that was a
Yeah.
question actually. So swimming. Swimming is, I think, a great way to stay healthy and work around some of the restrictions we talked about after a shoulder surgery. So during the rehab period, but also once you're recovered and healed, it's a tremendous way to keep the load off all your joints and get a great cardio and strengthening workout. So,
I've learned a lot about pickleball living down here in Charlotte.
fastest growing sport in America.
Yeah.
Next question. It sounds like this person wanted to know if arthritis can come after having labrum surgery or bicep surgery. I have an answer to that. What do you guys think about that? Do you get arthritis after those surgeries?
I think it probably the reason why you have labrum surgery or bicep surgery is usually the sequelae of some kind of an injury, and it's probably the injury itself that leads then to the progression of arthritis as opposed to the surgery. Maybe my thought on it.
Yeah.
Yeah, my first thought on that is there was probably arthritis already brewing in there already, and that it just hasn't really manifested itself yet, and that years down the road you get an x-ray and now we see arthritis, even though it was probably there in its earliest stages back then when you had the labrum surgery. Okay, survivorship. We wanted to ask about that. How long do these replacements last?
It's obviously the million-dollar question that we get asked every single day, and I think it varies a little bit. It's stratified by age and activity level. So my patients, if they're in the 70-ish age range and are golfers or tennis players or light yard work, I think they reliably last 20 years or more. I think if it's somebody who's 48 or 50 and still very active, doing manual work for their job that they're going to have to continue doing, then it's a little more unpredictable. You may be thinking more along the lines of maybe hoping to get 10 years out of a prosthesis in somebody that's putting a lot of physical demand on it. But there have been some good long longitudinal studies that show pretty surprising rates of survivorship at 15, 20 years.
Yep, agree. Dr. Mostak, this person does not want an MRI. What other imaging options do they have other than MRI that they can consider? Sounds like they're claustrophobic.
Okay. I would preface that with, trying to, the MRI is a great tool and you see it commonly performed. Ideally, if you're visiting an orthopedic surgeon, you would want that surgeon or physician to be able to have arrived at a pretty firm idea of what the diagnosis is prior to the MRI being performed. So often the diagnosis can be made clinically and obviate the need for an MRI. For things such as rotator cuff disease or rotator cuff tears, often will employ the use of ultrasound, which has fairly good sensitivity and specificity. It can be done even in the office. A lot of our clinics have ultrasound on site that can be performed in an examination room, or we can send you to an imaging center and have ultrasound performed. A few other exceptions: if someone has implanted metal or metallic objects that prevent them from having an MRI on the shoulder, we can perform a CT scan with contrast dye, which can give us a lot of the same anatomical definition, not as precise, but it can be used there. But I'd say probably the succinct answer to that question is ultrasound is a viable modality, especially for rotator cuff disease and biceps pathology, that can be used in lieu of MRI if a patient has an issue with claustrophobia or there's other reasons why they can't have it.
So we do ultrasound or a CT scan instead of an MRI.
Yes, sir.
Yep, so we got options there. Okay, Dr. O'Neill, this person is asking about stem cells. Dr. Schifrin talked about it for arthritis. What about for rotator cuff and impingement problems?
Yeah, I would go the same sort of, or I would just echo what Natty said. There's not a lot of great data out there saying that the stem cell options are going to help with the impingement or the bursitis. People are trying to augment repairs with what we call biologics, where we do repairs and then we stem cells, PRP, all different sorts of formulations, and some of them are some very expensive options which don't actually lead to improved outcomes. I think going to the side clinics like Shad had mentioned, where you're paying a lot of out-of-pocket expense, basically cash, to have these treatment modalities done, you'd probably be better served saving your money and seeing one of us and working through the problem.
Great. I had a good question. Here it is. This person is asking, when you have a complete rotator cuff tear, and let's all three of us answer this or go down the road, does it heal naturally? Can it heal naturally? And is that something you would treat with surgery or without? A complete tear of the rotator cuff.
I do not believe that complete tears of the rotator cuff heal naturally on their own, but as Scott mentioned, they are not all symptomatic, so not every single person who has a rotator cuff needs surgery. But I think if you really look at, does the tear mend itself back together, it does not.
Yeah, I agree with that. And then I would just add the caveat as to whether you need to have surgery or you don't. If you're having symptoms and you have exhausted the conservative measures, then you should probably consider surgery. Unless you're a young person with a traumatic tear, then pretty much I think all of us would say you just need to get this fixed.
I would agree with all of what's just been said. Rotator cuff complete tears have not shown the ability to heal. Some high grade or nearly complete but partial tears can be just as painful for a person as a complete tear, and sometimes in that situation we can use techniques to repair partial tears without having to take the entire tendon off, repairing in such a way that we repair just the part of the tendon that's torn away, not having to deal with the entire tendon. But short answer, no, they typically, once a complete tear has happened, they do not heal.
And just to clarify, a complete tear is where there's a segment of the rotator cuff that is fully detached from the bone. A partial tear is where there's just a small area, but there's not an area that's fully detached. So a lot of people have partial rotator cuff tears. In fact, probably well over 80% of people over the age of 60 will have it's some element of partial tearing, but full tears are a little different. Once that tendon fully detaches, your body does not have the ability to stretch it back out and get it to heal back to the bone on its own. Okay, I think we got like 2 more questions. So this person is asking, how do you know if you need a rotator cuff repair versus this reverse replacement you talked about, Dr. Schifrin?
Well, you know, I think we try in most cases to fix tears if they are repairable. And so if it's a tear that is of reasonable size and the tendon quality is adequate, we would rather fix the tear than go through a full shoulder replacement. The problem within that is that there are some tears as we get into the 70s, 80s age range, that the tendon undergoes natural age-related degeneration. And so the tendon quality itself can get to the point where the analogy I use to tell people is it's like trying to sew wet tissue paper together. If the tendon's not of good quality and we put one of those stitches in it, there's a high likelihood that it may fail. And so it's not always a clear-cut answer on those, but I think for the patients with adequate tendon, we would rather try a repair, and the reverse is more of a last resort for things we can't fix.
Last question here. We'll go down the road here. I think the gist of this person's question is kind of ranking the difficulty of rehab between different procedures. And they mentioned having a total knee or hip replacement. So kind of compare it to a total knee or total hip, because a lot of people have had those, or they've had friends or family that have had those, and they kind of seen what they've gone through. So tell us, is it harder than a total hip or a total knee? Each of the procedures you guys mentioned, kind of to get through the rehab.
I would say, from my perspective, not being a hip and knee surgeon, I would say most having done total knees in the past, most would say that the total shoulder is an easier rehab. Between the two main procedures, total shoulder replacement or reverse versus a rotator cuff repair, I would check with my colleagues, but the replacement tends to be an easier rehabilitation than a cuff repair, somewhat paradoxically. But again, much easier usually than a knee. You don't have to walk on your arm. So it tends to go pretty smooth and tends to be not a too terribly painful procedure.
Having pulled my patients about this over the years, total hips are the easiest,
Yeah.
fastest recovery. Total knees and total shoulders are neck and neck, kind of in that range. But I think shoulder recovery is probably a little bit easier than total knees. And Grant's absolutely right. What the odd thing is, if a lot of our patients that get the reverse replacement have had rotator cuff surgery and then they end up with a replacement, and
100%.
universally,
Yeah,
100% of them say that the recovery is easier and faster with the reverse replacement than it is with the repair, which
Yeah.
hard to explain.
Yeah. Rotator cuff surgery is no fun. It's not. It hurts. People get stiff. There's a lot of rehab. And I absolutely echo 100% of patients who have had a rotator cuff repair and then need to reverse it, down the road, all of them say the reverse is easier. Now, that's not to say that because you have a rotator cuff tear, you should just jump to a reverse because it's easier. Because there are some restrictions, and there's some risks with having the reverse, and there's a lot of benefit to having a good functioning rotator cuff. So, in the right hands, in the right situation, a good rotator cuff repair is always what we want to try and do.
All right, well, great, guys. Thanks a lot. Thank you, all three of you. Thanks for an engaged audience. Appreciate all the questions. I'll turn it back over to Elena.
Thank you guys so much for coming. We really appreciate it. And thank you guys for offering your expertise. If you liked tonight, all of it will be available, like I said, on Facebook or YouTube, on our social channels. This is the first part of a 7. Sorry for the live streamers. This is the first of 7 events that we're going to have, and they're all going to be here, and they're all going to be available on social. So keep an eye out for more content. All of these questions are great. We're going to spin those into something more digestible so you guys can have access to them at all times and kind of refer back to everything that they said. So thanks so much for coming. Please eat the food out there. It is all for you. If you want to take some, let me know. But thank you so much for coming, and we hope to see you again soon. Have a good night. Thank you. Awesome. Great job.
Flooded me with questions.
I know. So sorry.